everyone to the Brain Aneurysm Foundation's monthly webinar series. And we are really excited to have a different topic today and something that's really important to cover. It's the relationship between polycystic kidney disease and brain aneurysms. And we are thrilled to have with us Dr. Peter Czarnecki, who's a nephrologist at BIDMC, also a recent recipient of a Brain Aneurysm Foundation research grant, and Dr. Christopher Ogilvy, neurosurgery, also from BIDMC and founder of the Brain Aneurysm Foundation. So thank you everyone for joining. This is really a great topic and something that needs more awareness and education. So we're just going to hop right into the original questions. The doctors have some slides to share with you, and then we will go to some of the questions that people submitted and what shows up on chat. So again, welcome, thank you, and let's get started. So Dr. Ogilvy, the first question for you. Can you tell us what a brain aneurysm is and what some of the risk factors are?
Very much for the opportunity to be with you this afternoon. And it's a very exciting topic, as I hope you'll hear in the coming minutes. But to start off with your question, I'm Chris Ogilvy, as Christine said, director of the Brain Aneurysm, medical director of the Brain Aneurysm Foundation, and also director of our own endovascular and operative neurovascular surgery here at the Beth Israel Deaconess Medical Center, where we have a Brain Aneurysm Institute, which is very confusing for people. But in any event, to get into the questions, what is a brain aneurysm? Just to make sure everyone's on the same page, I think a lot of people on the line could probably give me this talk as well as I, and maybe even have seen some of these pictures. But basically, a brain aneurysm is, as you all know, hopefully an outpouching of the artery, usually where arteries divide. And this is just a cartoon that shows a sort of archetypical brain aneurysm, including being a little irregular in shape. But this is a spot of hemodynamic stress. And many brain aneurysms are thought to develop with time, and that'll be important later in the talks as we discuss monitoring patients and what are we looking for. But it's thought that there is a predisposed, possibly genetic weakness in the wall that over time can enlarge, become an aneurysm. Not tons is known about how these things grow and rupture. We do know a lot about size of aneurysm, but not about the pace of growth and why some of them grow at different rates than others. But basically, these can occur around the base of the brain, mostly in what's called the circle of Willis, and that's illustrated on this picture. This is a brain upside down. You can see what we call the posterior circulation, which are the vertebral arteries here coming together to form the basilar artery, and what are called the posterior cerebral arteries. And then the anterior circulation. These are the carotid arteries, the arteries you feel in your neck, but realize we're looking at it upside down. And right here, the artist has cut off the artery as it comes inside the head. But what this shows is that there's a communication of arteries at the base of the brain called the circle of Willis. And these are where aneurysms typically occur. And the artist has drawn here many aneurysms in many different locations all around this so-called circle of Willis. But this is what we're looking at, and depending on the location, the size, the patient age, these are different things that enter into treatment-related decisions. Here is an aneurysm, on a real vessel that I actually harvested at an autopsy. And you'll notice this is nice and smooth and round. It's about 5 millimeters in size. This is the so-called middle cerebral artery location, a very common location for aneurysms. But this was in a patient who died in a nursing home at the age in their 80s of a pneumonia, nothing related to her aneurysm. And we found this incidentally at autopsy. So this comes up as an issue now because instead of finding aneurysms at autopsy, we find aneurysms on scans all the time. Some of these are symptomatic and need treatment. Some are asymptomatic, and there's a whole discussion which goes with who to follow and who to leave alone. And it's going to enter into our discussions as we talk about polycystic kidney disease patients, because this becomes a very important factor. And some of the criteria are different based on a patient's own biology or own diseases. Now, risk factors you asked about for brain aneurysms, there is family history. And this can be found in about 20 to 25% of patients with intracranial aneurysms. And a family history is defined if there's two or more relatives in a bloodline. That would be a grandparent and a grandchild, an aunt and a niece, or an aunt and a nephew, a parent and a daughter or son. So if there's two or more relatives, there is recommendation for screening the rest of the family, which is usually done with MRI, MRA screening as a start, and then more detailed pictures as needed, if needed. So that's one big issue, is family history. Smoking is another huge influence on intracranial aneurysms. We recently have published a paper and reproduced in a multi-center study that the prevalence in women who smoke is probably on the order of 19%, or about 4 times the normal population rate of aneurysms, which is about 2%, but it can be as high as 20%. And we found this in a single center and a multi-center study. In men, we are just studying that now. It's probably going to be on the order of 10 to 12% prevalence, so less than women. And again, we're seeing here an influence of hormones on aneurysm formation. For unruptured aneurysms, in almost every unruptured aneurysm study, about 2/3 of them, or about 70%, are in women and about 30% in men. For ruptured aneurysms, it's more 60-40, about 60% in women, 40% in men. There are certain connective tissue diseases and rare syndromes which predispose patients to aneurysms. I didn't have the laundry list here, it'll mean less, but these are things we look for. And when patients are diagnosed with some of these rarer diseases, we look for intracranial aneurysms. And then autosomal dominant polycystic kidney disease, or AKPKD, or PKD, as a lot of people refer to it, polycystic kidney disease. And Peter will detail what this means, but this is another population of patients that when they carry the diagnosis of autosomal dominant polycystic kidney disease, we actually look for aneurysms in these patients. Now, the big fear of harboring intracranial aneurysm is not the unruptured aneurysm, but obviously when these things can burst, which is a subarachnoid hemorrhage. And here is a specimen that a pathologist pumped up with a blood-like sample of fluid to a very high pressure to get this aneurysm to burst. Here it is bursting from the dome of the aneurysm, which happens for a fraction of a second typically. And then the aneurysm seals itself off and gives us a chance to fix it in many of these situations. But this produces a subarachnoid hemorrhage, sprays blood around the brain, and as many know, causes morbidity and mortality as a result of this. Well, the decision-making comes when we encounter the unruptured aneurysm, and many factors enter this discussion. The size of the aneurysm is one issue. However, there are another bunch of issues that enter into it. And in decision-making process, we balance the so-called natural history. That is, what happens if we leave this individual and this aneurysm alone? What's the risk of hemorrhage over time? And that's balanced against the treatment. And the treatment can be endovascular, it can be surgical, but those we try to estimate accurately in a given individual what the treatment-related risks are. And both the natural history and the risks can be stratified when looking at different individuals based on age, size of aneurysm, location of aneurysm, et cetera. So the decision boils down to the natural history, that is patient and lesion-specific factors, as I've noted, size, location of lesion, age of patient, and then risk factors such as smoking, ethnicity, female sex, and then the risk of treatment, which again can be stratified by the patient and lesion-specific factors. An older individual has a higher risk than a younger individual. There are other comorbidities they may have, heart disease, lung disease. The risk of treatment has been decreasing, thankfully, over the last 30 years with improved technology and techniques. And we use open surgery or endovascular techniques to select the lowest risk form of treatment. And this is just a cartoon to finish up with, which shows here's an aneurysm in the middle of the picture. And these are the different factors which enter into our decision-making for the unruptured aneurysm. Up to the right-hand side, you see size. And the green, that is smaller, is thought to be lower risk to leave alone, whereas they get larger, the orange and red means that's higher risk. And location, here you can see the circle of Willis. Some locations are felt to be higher risk than other locations. The green locations felt to be lower risk. And then if there's irregularity of the aneurysm, a bleb on the aneurysm or a so-called daughter sac, so the shape of the aneurysm has an impact on this decision making. And off to the right here, we see if the aneurysm has increased in size over time. If you monitor an aneurysm for a few years and it's increased in size, that sometimes is a factor we use to help in the decision to treat. And way down in the corner here, we're working, as are others, on using MRI scans without and with contrast. We don't really know what this means yet. The BAF has funded a few studies looking at this, and it's a very interesting area. That is, can we tell which aneurysms might be more prone to rupture based on a scan? We're not there yet, but people are looking into this very avidly. Now, the topic for today's discussion, autosomal dominant polycystic kidney disease. Patients with this diagnosis carry a diagnosis of aneurysms in some 12%. Peter may detail that further. And size has less of an impact in these patients. Smaller aneurysms can be prone to rupture. So we have worked with our renal colleagues for years to care for these patients because as they're identified and their kidney issues are addressed, we often get involved with brain scans, how often to do that, what scans to get, and what follow-up is appropriate or treatment. And here is a patient was 61 years old. She had polycystic kidney disease, and it had reached a stage where her kidneys had stopped functioning well. And so she underwent a renal transplant, which was successful. She had a very strong family history of aneurysmal subarachnoid hemorrhage, and a couple of her family members hemorrhaged before this association was really well known between polycystic kidney disease and aneurysms. But some of her grandparents and in fact her parents, one of her parents had a hemorrhage. And so her brain was scanned. She had two findings. One was that her middle cerebral artery was actually occluded, but that was asymptomatic, didn't cause any symptoms. But she was found to have a small aneurysm. And here's her carotid angiogram. This is looking directly at the patient. Her eyeball would be about here on the left side. This is just looking at the left carotid artery injection. And as the blood comes up here, you can see as it turns into this artery, there's a small aneurysm present and a branch vessel coming off from that. Now, as aneurysms go, this is about 3-4 millimeters, is quite small. But I think you can even see on this picture, it's a little irregular in shape. And here's a three-dimensional picture of the same thing. You can see the branch vessel in irregularly shaped aneurysm in this polycystic patient. So we had a long discussion as to what to do. She was doing well on a renal transplant. She didn't want to have a subarachnoid hemorrhage. And we felt the safest treatment for this was actually surgery to clip the aneurysm. And here's what the aneurysm looked like at surgery. This is the optic nerve. This is the carotid artery, and it divides into the middle cerebral artery. And it divides. The middle cerebral artery is actually occluded up here. But this is the area of the aneurysm. And you can see, even though this aneurysm is small, and here's that branch vessel you could see on the angiogram, but the aneurysm is exceedingly thin and red, and the wall to this aneurysm was almost like tissue paper. And we were able, however, to place a clip across the base of the aneurysm here. And now the vessel next to it is left intact and normal. This was an elective surgery. And this patient was discharged 2 days after surgery on the third hospital day, returning to full back to work recovery. So I'm going to finish up there. I will thank you for your attention and hope that was somewhat informative in a background to couch the discussion that we're going to have, and that I think Peter's going to take the lead in a lot of the questions, but hopefully fill in some of the blanks.
Thanks, Dr. Ogilvy. That was great. Really appreciate that introduction. And now Dr. Czarnecki, thank you again for giving your time to this webinar. We really appreciate it. Can you tell us a little bit about what polycystic kidney disease is?
Yes, thank you. And again, thank you so much for having me. And I may just use this to also share a few slides with you. I have to do the share screen business here. Tell me if you can see this.
Yes, we can see that.
Okay, that's just like a little intro slide. Yeah, so so I'm the director of the Polycystic Kidney Disease and the Kidney Genetics Clinic here at the Beth Israel Deaconess Medical Center. And we are proud to announce that we have just been receiving the accreditation by the Polycystic Kidney Disease Foundation as one of the few national centers of excellence. So that gives us a little bit more visibility, and we definitely see more patient referrals to our clinic, and we hope that this is a positive trend that will continue. Going back to your question, what is polycystic kidney disease? Well, I show you some epidemiological facts and numbers. So it is one of the most common genetic diseases in humans. 1 in 400 to 1 in 1,000 live births is affected. So if every one of you just thinks back, like how many people have you met in your lifetime, or like, you know, going from your neighbors and the street where you grew up, and then, you know, coming from elementary school through high school and college, everybody probably knows maybe 5,000 people, maybe 10,000. But if you know 5,000 people with whom you have crossed paths in the past few decades, then there are already 5 to 10 people who have polycystic kidney disease and who will go on dialysis or who will need a kidney transplantation in their future. You may have lost contact with them. You may know nothing about this. They might have known nothing about it when you were classmates, but the number is pretty high, and we always tend to think about genetic disease as something esoterical, you know, that there is something in the DNA, and that like rarely somebody gets involved with this. But I want to emphasize with showing you these numbers how common it actually is, and our clinic is full with new referrals because it gets increasingly recognized. What is it all about? People who have polycystic kidney disease, they start having tiny little cysts, like little fluid-filled sacs in the kidney, and they don't do anything bad per se. They're not cancerous. They're not like infiltrating anything. They're just the only thing that these little cysts do is they grow, and they grow throughout the patient's lifetime. That means that if the patient is young, there may be hundreds or even thousands of tiny little cysts, but if they're only microscopic size, they are not even recognizable. Even if you scan people at childhood age, you may not see anything. But when people get older and older, these cysts grow, and then they at some point become maybe pea size, and maybe at some point they just become like nickel size, and grow and grow. And in many people, in the classic form of polycystic kidney disease, the kidneys become so large from these fluid-filled bubbles that the kidney tissue that tries to do its job gets squished between those expanding cysts. And in the classic form of polycystic kidney disease, the majority of patients has to go on dialysis because of kidney failure, or will need a kidney transplantation. And in the vast majority of people, that happens probably in the 5th or 6th life decade. So in the most common form, type 1 disease, the average start of dialysis falls around age 55. So if you look at everybody in the United States who is on dialysis or who received a kidney transplantation, then the small numbers, 4 to 10% of them are on dialysis or have a transplant kidney because of PKD. That number doesn't look large, but that's probably only because we have so many patients with kidney disease from diabetes in this country. If you look in other populations, like in Southern Europe or in Japan, where people have less diabetes and less obesity and metabolic syndrome and kidney complications from that, the number of people who are on dialysis because of genetic disease or polycystic disease is larger. So worldwide, we probably have, up to 15, 17 million people who have this. We are here at this forum here with the Brain Aneurysm Foundation because there is a significant overlap that is now recognized between polycystic kidney disease and the incidence of brain aneurysms. As Dr. Ogilvy said in his little slide presentation, if you look at all comers, like off the street, how often would you find a brain aneurysm? And it is probably in the magnitude of 2% of all the people out there. And in many people, as in the autopsy case, they may have an aneurysm that is maybe 5 millimeters large, and it's sitting there, and it never gives rise to any problem. We don't know that, and we try to learn from observing many cases and try to risk stratify them. But it is the fact that in patients with polycystic kidney disease, the number is higher, 10 to 12%. So that's 5 to 6 times higher than in the normal population without polycystic kidney disease. And we also know that these aneurysms behave differently. They are more likely to rupture, even at smaller sizes, even at younger ages. So that's why we are concerned. And that's why for us kidney doctors, and particularly for the polycystic kidney disease experts, it is one of the most important topics to address this issue when we see patients, and many patients are unaware, and unfortunately also many physicians are unaware of this. So I really appreciate the opportunity to talk here, and also all similar forums just to address this large area of definitely of unmet need. This is a CT scan of a patient with polycystic kidney disease. It's a little bit blurry here, but basically this patient came to the emergency room because of stomach pain, and they thought it may be appendicitis. But then they obtained a CT scan, and here on the CT scan, this is a reconstruction where you basically cut the patient in slices coming from the front and scrolling through the back. And this is at the level of the kidneys. And for those who may focus in here a little bit, I outlined the circumference of the perimeter here of the kidneys in yellow, and these are gigantic kidneys. You see that the shape is irregular. The normal kidney is like kidney bean shape, but here you see these bulging bubbles. This is a huge cyst that is at the inferior pole. This is just the pelvis of the kidney, but basically these kidneys are 3 times as big as what they should be. And it's not good that they are so big, because all that additional volume is from cysts that exhibit a mass effect and that impinge on the normal kidney tissue. They cause diversions in blood flow to the normal kidney tissue. They compress the kidney tissue. They cause fibrosis and scar tissue formation. And then ultimately, these kidneys will lose their function at some point, and the patient will have to go on dialysis. So, okay, I may just stop the slideshow here. This is and unshare my screen, because how do I do this? Stop share. But I wanted to exemplify with my slides what polycystic kidney disease is all about, how it looks like, And I think I want to return back to you, Christine, because you have more questions prepared for me and for Dr. Ogilvy.
Peter,
Perfect.
may I just ask, connective tissue, kidney, get a cyst, connective tissue, brain, get an aneurysm. That's a connective tissue problem. That patients don't get do they get other connective tissues issues elsewhere in the body? In other words, aortic aneurysms, other types of aneurysms, joint laxity, other things that are related to connective tissue. It's always been a fascination to me that it's two targets kind of in the brain.
Yeah,
Or in the body.
and if we think about polycystic kidney disease, we pathophysiologically don't necessarily think about the connective tissue to be affected. If we look at the mechanisms, for example, how the major PKD gene products work, they seem to work a little bit in a different way than governing connective tissue anatomy. But the truth is exactly what you say. We find vascular abnormalities in many other provinces, not only the brain. There are sometimes heart abnormalities. There are sometimes abdominal aortic aneurysms that have different mechanisms of pathogenesis than brain aneurysms. We sometimes see mitral valve prolapse in patients with polycystic kidney disease that falls a little bit into the same category. It doesn't seem that like joint laxity or things that are like classic like orthopedic connective tissue, that they fall into the same spectrum. But as far as the vascular system or the mitral valve, like the heart, are concerned, we see these parallels. And then there are other extrarenal manifestations because you can have cysts not only in the kidneys, but we see cysts often in the liver. We see cysts very often in the pancreas. We see cysts, which brings us back to the brain again, in the arachnoid. There are arachnoid cysts that, however, these are usually foci that not necessarily cause a lot of clinical concern. Most people who have polycystic kidney disease, when they require some medical intervention, it's either in the late stages of kidney failure, or it is through accidents and catastrophes like an aneurysm rupture.
Great, thank you. Appreciate that. Dr. Ogilvy, back to you. What usually comes first, brain aneurysm or PKD? And would it be common for a PKD patient to be scanned for a brain aneurysm?
So in today's environment, typically the polycystic kidney disease is identified first, usually because of renal issues. And in our center, Peter will see them and scan their brain. And if something shows up, then I'm asked to get involved. I have seen situations where a patient will come in with a subarachnoid hemorrhage from a small aneurysm or any aneurysm. And lo and behold, as we start taking care of that patient and looking closer, they do have a cyst in their kidney or polycystic kidney disease. That is less the case these days. It's more the case that they are now being screened because of the numbers you saw and the prevalence of this for aneurysms.
Thank you. That was a good answer.
Also, if I may chime in here,
Sure.
I want to say there is a little bit a paradigm shift that is happening right now, and to the favor of many patients. Because when I was back in medical school and when I was training, I was already interested in polycystic kidney disease for other reasons, but it was not a strict recommendation that everybody who is newly identified with polycystic kidney disease needs to be screened. And even up until a few years ago, the textbook knowledge that is being propagated was, yeah, if there is a patient who has newly identified polycystic kidney disease and if they have a high-risk profession, like an airline pilot or a school bus driver or a crane operator or something, then we would preferentially screen these people. And in all the other patients who don't fall into this category, there was a little bit of there was no consensus. There was some shoulder shrugging. But I think what is one of the good developments is that imaging has become so much more available and accessible that right now it is not a big deal to obtain an MRI scan on somebody who is being seen for polycystic kidney disease. And I have the feeling that like 20 years ago there was a little bit more like of a reluctance. How do I justify the screening if this patient is not a high risk category and I don't know, and what if the result comes back like indeterminate? What do I do then? And I always try to advocate identification comes first. And if your aneurysm is large or small or indeterminate, I'm not the expert for the aneurysm, but I make the first call and I identify the patient. And if I have identified an unruptured aneurysm, then I may have already saved a life. But I send them to the Aneurysm Institute, and then experts like Dr. Ogilvy pick up these patients, and they may also not have the right treatment like that right that very second. And sometimes, you know, he ends up observing these patients with serial scans, but at least we have it on the map. And getting to that point, I feel, is already a huge success.
Thank you for sharing that, Dr. Czarnecki. The next question for you is the relationship between PKD and brain aneurysm patients something that nephrologists usually share with their patients, and how important do you think it is for that to happen?
Okay, I might have already partially answered that question, but I think I want to emphasize that recommendations are changing, and I think they're changing in favor of more screening, because more screening will also mean more detection and less uncertainty, hopefully, when those patients who have a newly detected aneurysm can be then, you know, referred to an aneurysm expert in an academic medical center, and at least be on the map, even if they don't need surgery or intervention right away. But I feel that knowing is better than not knowing, and identifying these aneurysms early is always a potential life saved. People with polycystic kidney disease, they may have complications over years and decades, ultimately leading to dialysis or kidney transplantation. But this is a very slow process. I can prepare my patients for this. We can even identify living volunteer kidney donors and have a plan A and a plan B for all the kidney-related complications. But if a patient suffers from a brain aneurysm rupture, that is lethal in 50% of all cases. And I think that is absolutely necessary to continue, you know, spreading the word and raising awareness of the importance of this issue. Yeah.
Super, thank you. And recently you received a research grant from the foundation. Can you tell us?
Can I just add one little thing? Pardon me, Christine. Can I just add one little thing to what Peter was saying?
Sure.
And
Sure.
that is that at the present prevalence of aneurysms in polycystic patients, there have been studies demonstrating what's, you know, called cost effectiveness to screen. Because the Brain Aneurysm Foundation, Peter, has a big campaign, Scan to Save. That is, when people have a bad headache, they should get a scan. That's not everywhere. And there's a lot of controversy about screening tests, because whether it's for cancer or brain aneurysm, we're looking at it in different populations of people. We've proven that in women who smoke, they should probably have a scan. In polycystic kidney disease patients, you should probably have a scan. Now, cost effectiveness, there's really two meanings to that. One is the cost to society. What's the monetary cost to screen? The idea being you have to pay money to do these scans, but it's cost effective because if someone is hurt by one of these aneurysms, that's a huge cost to society. So it's been shown to be cost effective to screen polycystic kidney disease patients, both monetarily, and the other cost, of course, gets to personal cost. That is, what's the cost, as you just alluded, of missing one aneurysm and having it hemorrhage, which can be huge in terms of mortality or a deficit or a stroke. Sorry to interrupt, Christine. Thank
Yeah, no, thanks, Dr. Ogilvy. That's great. So back to Dr. Czarnecki, I just like you to elaborate a little bit on the project that you just received a grant for from the foundation, what it hopes to achieve.
Yes, we are super enthusiastic about the research funds that we have received from the Brain Aneurysm Foundation, and we want to go the opposite way, namely not starting with the patients who already know that they have polycystic kidney disease. In our clinic, they get screened for an aneurysm regardless, but we want to start with the patients who are coming to the aneurysm clinic, and we want to see how many have any kidney disease, particularly polycystic kidney disease, that they don't know of, because polycystic kidney disease comes in many phases. As I said, the most common forms are the ones that we know about in the textbook and that the patients know about because it's highly penetrant and highly aggressive, and multiple generations of a patient have that in their family history. But a different phase of polycystic kidney disease are those that are slow, that are subclinical, that not necessarily lead to advanced kidney failure. So patients, live with it and live a happy life and oftentimes never know about this. But if they have the gene mutation that is causing this, that may also predispose them to the formation of a brain aneurysm, and that may be the most important determinant of their morbidity and mortality. So we want to tap into the brain aneurysm population, and we want to use our genetic screening tools to identify how many patients with genetic mutations are there that we can actually pick out, because I believe if we had a screening tool that is somewhere between doing nothing and then jumping ahead to a brain MRI scan, which is a simple blood test, maybe that may be an additional diagnostic layer that may help stratify patients at risk, particularly if there are family members who are affected and nothing is known about inherited kidney disease. Yeah.
Excellent. Thank you so much. We're really excited actually that you got this project. It's a little outside the norm of what some of the research is, but I think it's really important. So it's very exciting. So Dr. Ogilvy, how important do you think Dr. Czarnecki's research is, and what impact do you think it could have on identifying brain aneurysms in unsuspecting patients?
Well, we're just getting into this, and it's proving to be very interesting. And when I say we're just getting into it, I'm actually working with Peter on his grant. And in our aneurysm clinic, we have a young woman who helps patients get in the room, and she's very bright. So she's screening every patient and asking them, have you ever had a scan of your belly? Ever have any kidney issues? And we are finding a much higher percentage than I ever knew, because sometimes we didn't ask this question. We'd say, do you have renal disease? Well, renal disease is pretty obvious and can be severe. But subtle renal disease, that is a cyst in the kidney. Oh, I had an ultrasound of my belly once, and the reading said cyst in my kidney, which, as Peter said, is thought to be a benign thing. Well, there may be sort of genetic variants of polycystic kidney disease. In other words, when he says penetrance, he means genetic penetrance of the disease, where if you have all the genes, you have the full-blown disease, but a few of the genes, you might have a little of the disease. And maybe that predisposes to aneurysm formation. Someone asked in the chat, with having an aneurysm, should kidneys be tested? Well, it may come to pass that the answer is yes. Now, the other thing about polycystic kidney disease is lots of the ways we look at aneurysms, that angiogram I showed you, the CAT scans, we use dye. And a lot of that dye is removed by the kidneys. So sometimes we have to handle these patients a little carefully, in the sense that I've taken care of and even operated on patients without giving them any dye. We just use an MRI, MRA. You don't need to give any dye. So this is another thing that has to be taken into account. But his research is really just getting going, but it's already showing some things that we had not expected, to be honest with you. So I think it's very exciting.
Excellent. Thank you both so much. Right now, we're going to go over, I'm going to toss it to Lynn Nuttall from the BAF office to ask some of the questions that people put in when they registered. So Lynn, if you don't mind doing that, that'd be great.
Yep. So there's quite a few here. Let me see. What lab tests need to be ordered to determine polycystic kidney disease?
So nowadays, there are very sophisticated genetic tests that are not part of the normal diagnostic routine in the lab. So the easiest test for polycystic kidney disease is the combination of having imaging in form of a CT scan or an MRI scan of the kidneys and see if there are cysts present. And even in people who have very few or very small cysts, or people who don't have a family history of disease, they may still have a gene mutation in the polycystic kidney disease genes. So the genetic tests are usually not performed at the standard clinical lab sites. The genetic tests are also becoming more available than what it was in the past, but that's something that a kidney specialist has to order. We get typically the easiest lead that there may be polycystic kidney disease present is from previous imaging, like if somebody comes to the emergency room and has a CT scan performed, and then there are kidney cysts detected that were yet unknown.
Okay, thank you. Here's another. What are the symptoms of polycystic kidney disease, and is there a link for patients with a family history of kidney disease?
Yes, and so as I said, as a genetic condition, particularly as a genetic condition that is inherited in the so-called dominant mode, it means that if a patient has polycystic kidney disease, it is almost 100% certain that one of the parents either has it or had it. We don't necessarily know. Sometimes somebody's parents have passed away early, or not much is known about their medical history, and very rarely it happens that we identify polycystic kidney disease in a young person, and then we open the book and we find the same disease in some of the siblings and in some of the parents, and the parents didn't even know about that. Yeah, so that's a little bit how it comes to another. In the more severe cases where previous generations experience more severe kidney disease, all the way to the need for dialysis, it is usually very well known that this is running in the family. So in those patients, there are usually no major surprises. They come to our clinic for an initial visit, but they already know everything because they have seen the disease in their parents or in their uncles or in their siblings, and then they're already polycystic kidney disease experts the moment that they show up for a visit in the kidney clinic.
Okay, and again, some of these I'm not sure if they're going to be going over things you already answered, but this says, I've been suffering 6 bladder infections in the last year with no obvious correlation. Should I ask my doctor to consider this?
No, bladder infection is not a common presentation that is specific for polycystic kidney disease, and I want to say it is also not. It's a common condition also for many other people, to have even if you don't have polycystic kidney disease. However, oftentimes it is it is very easy to perform a screening ultrasound. Yeah, you don't need to go for a sophisticated genetic test if there is any suspicion. You don't need to have an MRI scan or a CT scan right away. Oftentimes, if in the same office location or so, an ultrasound can be performed very quickly. That is something that is done within 10 minutes, and it's only about the presence or the absence of kidney cysts. If you don't have any kidney cysts, yeah, then at the age of 30 or above, I would say it is pretty likely that you don't have polycystic kidney disease. Yeah, and a screening ultrasound can be ordered very, very quickly by a primary care physician.
Okay, thank you. Another question is, are there other diseases that could be connected to a brain aneurysm?
Is it, you mean other kidney diseases, or yes, there are
Like you said, the other diseases.
there are other connective tissue diseases. There's primordial dwarfism. Some forms of Ehlers-Danlos is thought to be related, although it's not a tight correlation. Again, these are defined connective tissue disease that sometimes the rheumatologist deals with. And we're finding some variants of those. Some aneurysm patients seem to have almost a syndrome. They have aneurysms, they have other connective tissue problems, and it's not even a named disease yet, but there's obviously some predisposition there. And in some of those patients, there's a family history of aneurysm.
Okay, thank you. Another question. I've had 2 brain aneurysms, 1 ruptured. Now I have kidney failure. Are they related?
Yeah, excellent question, but I think we have to take a step back and see what came first in that sequence, and what is the chicken and what is the egg. And oftentimes it can be true unrelated. Yeah, if you had a ruptured aneurysm that was fortunately discovered and treated accordingly, it often makes people still critically ill, and people sometimes stay on intensive care units for an extended period of time after a significant subarachnoid hemorrhage, and oftentimes prolonged hospitalizations can be complicated by acute kidney injury for many different reasons, with or without pre-existing polycystic kidney disease. So I think we have to separate a little bit. Is there a disposition already, and is there pre-existing kidney disease that led to the formation of an aneurysm in the first place? Or is it so that the kidney was perfectly fine before everything happened, and then with an aneurysm rupture and with the hospitalization, that the kidney suffered from complications of the critical illness and maybe of the contrast and of those interventions, and we can see that absolutely in patients with no pre-existing kidney condition. After the facts, it's still possible to separate these things, and a genetic test, for example, would tell if or an imaging study would also tell if there were any structural abnormalities or if there were any genetic factors. Yeah, but these 2 problems may be separate from one another.
Okay, there's a question in the chat now from someone. It says, I have PKD and 3 brain aneurysms. My 4-year-old granddaughter has a brain cyst. Should she be screened either genetically or by a scan?
I think this is a question that we may both answer. I don't know. Chris, do you want to start, or do we want me to start?
No, yeah, I think you could take this, but because my response is going to be, this is a person we're going to have particular interest in over time. Although only 4 now, this is something that needs to be followed up over time.
Yeah, I think so. So I think when you say brain cyst, I don't know if this is an arachnoid cyst or if this is what the nature of that brain cyst is. So I don't think that I can comment specifically on that, but it is real that the polycystic kidney disease, if it is present in you, the chance of passing it along to anybody of your present or future children is 50%. And it's a dominant disease. So you have two chromosomes, one with a healthy copy and one with a disease copy of the polycystic kidney disease gene. And when a new child is not born, when a new child is conceived, then you pass along one of the two. And nature throws the coin. Yeah, it is either the disease copy of the gene or it is the healthy copy. So if your daughter has only the brain cyst, it doesn't necessarily mean that she also has the polycystic kidney disease, and it also doesn't mean that she automatically has the brain aneurysms, but those things go together, and it's not impossible. I would really listen very carefully what the pediatric experts say, with whom you are already in touch, and the genetic tests and the imaging studies for the kidney can also be performed on a 4-year-old. But the question is, how is the risk of any further complications being assessed, and is it advisable to screen 4-year-old patients? And I think that's maybe something that Dr. Ogilvy is better at answering. What do we know about aneurysms in pediatric age?
Yeah, if it's a patient who has polycystic kidney disease, I think they would be screened. And if there wasn't an aneurysm, then some interval would pass before another screening would be done, probably in a patient like that, 5 to 7 years. And once they're older, even longer, maybe 8 to 10 years, something like that. Because the question is, can they form aneurysms? Because we don't know when these aneurysms form, but that's how we do surveillance.
Yeah.
Okay, thank
In my
you.
clinic, we usually don't advise necessarily to young parents to screen children, but we usually recommend screening children for polycystic kidney disease once they are like through high school and once they are in a life situation where they take charge of their own lives and start making decisions. And it's important, when you send them on their way, that you that they know and can make calculated decisions, and then knowing that they have genetic kidney disease, irrespective of the brain aneurysm risk, is then something that comes up. Then some parents really want to know, and we say, like, if the children are very unlikely to suffer from the polycystic kidney disease itself, but we see, for example, children with high blood pressure, and that may be the first sign that the polycystic kidney disease is present. But then we recommend then treat their blood pressure, and have them grow and have a normal childhood, and then if they have more complications, then we can talk again. Yeah, that's a little bit our approach to counseling parents with polycystic kidney disease.
Okay. There is another question in the chat. My parents are on this call as well. My dad and his whole family has had PKD and transplant. My sister passed about almost 2 years ago at the age of 43 from a ruptured giant aneurysm. We don't know if she had PKD, never showed signs. Could there be a gene without the cyst?
Excellent question, and that's something that we're trying to get at when we screen populations who come primarily for an aneurysm problem and who may not even know that they have polycystic kidney disease. But I want to say, if polycystic kidney disease is known in a family, it doesn't necessarily mean that every family member knows about it already. They may have it already, and they may become symptomatic from an aneurysm rupture years or decades before they become symptomatic from kidney problems. That's why that's one of the points that we try to emphasize when we talk to patients, when we talk to colleagues, and when we talk to, you know, larger organizations. Yeah. So if there is a family history of polycystic kidney disease, not everybody may know that they have polycystic kidney disease, but if somebody has, for example, a sudden unexplained death or a brain hemorrhage or so, then it's still speculative, but it's very easy to connect the dots. Yeah. And chances are very high that this has exactly happened.
Okay, and after that, there was also what gene would show up in genetic testing, and why is it that insurance does not always cover if there's a family history?
Yeah, I hope, and this is wishful thinking, but I believe that we are also in a time of a paradigm shift for the genetic testing. Yeah, because genetic testing was considered something that is like, you know, esoteric and like kind of nerdy, you know, in the scale of diagnostic tests that are being offered. But right now, it really, I mean, ordering a genetic test that contains the risk genes for polycystic kidney disease, and there are more than one. Yeah. It literally takes me 30 seconds. And there are situations where the insurance has questions, or where they need a prior approval letter or a phone conversation with the medical liaison. But I have personally conducted and also supervised genetic tests on more than 700 people, and I didn't have a single situation where there was an unresolvable conflict with the insurance company. There are some people who have an insurance that requires patients to come up with a certain copay for certain tests, but I think there is an increasing awareness of the cost effectiveness and of these tests, and we recognize more, we prevent more morbidity and mortality, and that's also something that Dr. Ogilvy said, that screening with MRI was in the past not recommended, but now it is considered as being cost effective, because then, you know, if you think about not only the cost to the person, but also the cost to society and the insurance system. You know, if you prevent complication from one case that you detect. I hope this is a movement that continues in the same direction, because over the past years we have seen much more accessibility to affordable genetic testing, and this will hopefully continue.
Thank you for that. We're just going to ask one more question so we stay on time and we can wrap everything up. And it is, does PKD increase the rate of aneurysm formation and or rupture?
Oh, yeah. Yes. I mean, that's the point, is that the prevalence of aneurysms in patients with autosomal dominant polycystic kidney disease is 10 to 12%, whereas with, you know, the general population is thought to be around 2%. So that's true. And it also seems, although the data is a little harder to get at, that's what I was making the point about, this whole size of aneurysm versus rupture, which is a lot of literature in non-polycystic patients. We see a number of patients with smaller lesions rupture. And so that pushes us sometimes to be a little more aggressive in treating those patients before they rupture.
All right, thank you.
Think about what the society does for the early discovery of any diseases, right? For breast cancer, I think it's a single digit percentage of women who go for annual mammogram screening. In colon cancer, it's 1 in 25 adults who will develop it, and we do colonoscopies starting at the age of 45 now, I think, or 50. I don't even know the guidelines, but in the polycystic kidney disease world, the moment that a new patient comes into my clinic room, I know that there is already a chance of detecting an aneurysm that is 10 to 12%. If I take a family history and the patient tells me that they had somebody in the family who already had an aneurysm diagnosed or ruptured, or who had a sudden unexplained death, that chance goes up to 20 to 25% before I even see the results from the MRI scan of the brain. Yeah, so I just cannot emphasize it enough how important it is, particularly in this enriched population. The risk is very high, and we should do more about it.
Well, excellent. Thank you so much, Dr. Czarnecki and Dr. Ogilvy. This was really great information. And again, this is going to be just looked at. If it needs to be edited at all, we'll have it emailed to everybody who registered and out on our YouTube and shared on social media in the next few days. So this concludes our year-long monthly webinar series. So this is great. We had one every month. I'm going to keep it going in 2024. And I just wish everybody a wonderful holiday season and a very happy new year. So thank you so much.
Thanks very much, Christine.
Yeah.
Thanks for having us.
Thank you.
Okay. Bye-bye.